Hi, good morning, all of you. Am I visible and audible to you? Just show me a thumbs up in the chat box if I am visible and audible to you. Good morning, good morning. Just show me a thumbs up. Show me a thumbs up so that I come to know that I am visible and audible to you. Chalo, that's very good. So today, early morning, we all had to get up. But it was very important because this is a very important topic which I'm going to do with you, and I wanted all of you to be very fresh for this topic. Now this is one of those topics जिसमें question आता ही आता है. You should expect at least one question, at least I am saying at least one question from this topic in any exam which you write, and you will be surprised to know that in INI set last year in June 2021 session there were 4 questions from this topic, right? So a very important topic for all of you. Now since I want to complete the entire topic on time, so I have pre-made a few slides and I am just going to explain to you and I am going to write in those slides. Now suppose you are unable to catch up with the writing part. I want you to first understand the concept. Writing part के लिए this video is going to stay there till tomorrow. So this video will be uploaded on my channel till tomorrow, and till tomorrow anyone who wants to watch it n number of times can watch it, right? Clear? So let's start with primary amenorrhea. But before you understand primary amenorrhea, it is very important for you to understand certain embryology basics. And as these days there is a lot of stress on integration. So ये तो पूरा टॉपिक ही इंटीग्रेशन बेस्ड टॉपिक है जहां पे हमें एम्ब्रियोलॉजी एंड OBGY we have to integrate the topic and we have to study it, right? So first I'm going to tell you a few important things in embryology related to this topic. So the first important point and the first important question which is asked is, how is the sex of a baby determined? So sex of the baby is determined by a gene which is called as the SRY gene. Very important. This is an SRY gene, that is sex related gene present on Y chromosome. SRY gene. Now this gene, as the name itself is telling you, that it is located on Y chromosome. But knowing this is not just enough. What you have to know is that this Y chromosome where is it located? It is located on the short arm of Y chromosome. On the short arm of Y chromosome in the distal part. So SRY gene is located on short arm of Y chromosome in the distal part of the short arm of Y chromosome. Now, if Y chromosome is present, that means SRY gene will be present, and that means sex of the baby will be male. And if Y chromosome is absent, so SRY gene will be absent and sex of the baby will be female. Right? So whenever Y chromosome is present, we say sex is male, and whenever Y chromosome is absent, it means SRY gene is absent, and then we say that the sex of the baby is female. Now a very simple thing, right? So this means if I ask you that what do you think will be the sex, sex according to their chromosomal makeup, right? So what is the other name for chromosomal makeup? Chromosomal makeup is called as genotype, and it is also called as karyotype. So as per the genotype, if I ask you, Turner syndrome babies, they are males or are they females? So just now I told you the concept that if Y chromosome is Shashi, nothing. Just join quickly, and I have just told you very few fundamental things just now. And the fundamental thing which I have told you just now is the sex of the baby is determined by SRY gene. SRY gene is present on the distal arm of the distal end of the short arm of Y chromosome. If Y chromosome is present, in other words, SRY gene is present, then the sex of the baby will be male. And if Y chromosome is absent, that is SRY gene is absent, then sex of the baby will be female. That's all what I have told just now. So now I am asking you that as per genotype, as per the chromosomal makeup, what do you think will be the sex of Turner syndrome baby? Turner syndrome baby, they are 45XO. In other words, there is no Y chromosome. And if Y chromosome is absent, they are going to be female. Whereas if we look at the genotype or the karyotype of Klinefelter syndrome baby, Klinefelter syndrome is 47XXY. Now because Y chromosome is present in Klinefelter syndrome, they are males. Although they have two X chromosomes, but still we say they are males. Why? Because sex is determined by Y chromosome. Sex is not determined by X chromosome. Clear to all of you? Now, tell me, once a baby is born, how do you tell the sex of the baby to the patient? How are you going to tell the sex of the baby to the patient once a baby is born? You look at the external genitalia. So after birth, the most common method of sex determination is by looking at external genitalia. But then this is not the best method for sex determination. Why this is not the best method? Because there are conditions where the sex you will not be able to tell the sex of the baby properly because the genitalia will be ambiguous, right? So in some cases, there can be ambiguous genitalia. Ambiguous genitalia means where by looking at the external genitalia, you will not be able to tell the sex, right? That is why sex determination by looking at the external genitalia is not a very good method, right? Then there is one more method to determine the sex of the baby, and that is by the number of Barr bodies. It is by the number of Barr bodies. Number of Barr bodies is number of X chromosome minus 1, right? Number of X chromosome minus 1 is the number of Barr bodies. Now again, this is not the best method. This is not the best method for sex determination. Always remember that the best method for sex determination is karyotyping. Best method for sex determination is karyotyping, right? Now, I told you why looking at external genitalia is not a good method because of ambiguous genitalia. Similarly, now I am going to explain to you that why by the number of Barr bodies determining the sex is not a very good method. So, if we see what are the number of Barr bodies in a normal male. A normal male, the chromosome number is 46XY, right? 44 plus XY, or in 46 in brackets XY. Now, because there is only one X chromosome, So 1 minus 1, that is 0. So what is the number of bar bodies in males? 0. Number of X chromosomes minus 1 is the number of bar bodies. In a normal female, 2 minus 1, and that is 1. In Turner's syndrome, 1 minus 1, that is 0. And in Klinefelter's syndrome, the chromosome number is 47XXY. So over here, 2 minus 1, and that is 1. Now, just now I was telling you that as per karyotype, Turner's syndrome babies are female babies. And as per karyotype, Klinefelter's babies are male babies. But if you look at the number of bar bodies, in Turner's syndrome, bar body is 0. Right? Whereas in Klinefelter's syndrome, bar body is 1. Which is just the opposite of what happens in a normal male and in a normal female. That is why number of bar bodies is not a very good method of sex determination. Right? Is this clear to all of you? Now, when we use the term sex of a baby, now the sex of a baby is determined by 3 things. There are 3 things when we are talking about sex. One is sex as per genotype, right? Then sex as per the gonads, and then sex as per external genitalia, right? So when we say sex, it means it has to be sex as per genotype, sex as per gonads, and sex as per external genitalia. Now in males, genotype is 46XY, gonads are testes, and external genitalia resemble male external genitalia. Whereas in females, genotype is 46XX, gonads are ovaries, and external genitalia are female-like. Now, when all these 3 things correspond to each other, that is, chromosome number in male should be 46XY, gonads should be testes, and their external genitalia should look like male, then I say that yes, their development is normal. Their sexual development is normal. Similarly, in females, when chromosome number is 46XX, their gonads are ovaries and they are functioning, and their external genitalia are looking exactly like a female external genitalia, then I say that there is normal sexual development in a female, right? Now, if any of these 3 things is not normal or it is not corresponding to each other, then we say that there is a disorder of sexual development, right? So disorder of sexual development could mean anything. It could mean that in a male, the chromosome number is 46XY, but the testes are not functioning, or the testes are absent, or the external genitalia are looking like females. Then that is a disorder of sexual development. Have you understood? So all these 3 things should be normal. The chromosome number should be normal, the gonads should be normally functioning, and the external genitalia should be exactly male or exactly female. Then we say there is normal sexual development. Is this clear till here or to all of you? Yes? Quickly show me a thumbs up in the chat box so that I come to know that till here you have understood. There is some lag over here. I'm just waiting for your thumbs ups so that I can proceed. Okay. Got it. So you've understood till here. Now we are going to talk about each of these things. I have told you about karyotype 46XX and 46XY. Now I am going to talk to you about formation of gonads. Now in formation of gonads, you have to remember a very important question, that from where are the gonads formed? Gonads are formed from genital ridge. Whether it is testes or whether it is ovaries, it is formed from genital ridge. If Y chromosome is present, gonads will be testes. If Y chromosome is absent, gonads will be ovaries. So Y chromosome present, gonads testes. Y chromosome absent, gonads ovaries. Now gonads are formed by 7 to 8 weeks of intrauterine life. Testes are formed earlier than ovaries. Now testes, the development is very simple. If Y chromosome is present, then the gonads will be testes. If Y chromosome is absent, then gonads will be ovaries. Now in ovaries, you have to remember that for presence of ovary, so that the gonads are ovary, what is needed? Absence of Y chromosome is needed. So Y chromosome should be absent, then only gonads will be ovaries. Till here it is right. But then remember, for presence of ovaries, we need absence of Y chromosome. But for proper development of ovaries, both X chromosomes are needed. Both X chromosomes are needed. So for presence of ovaries, we need absence of Y chromosome. But for proper development of ovaries, both X chromosomes are needed, right? So let us see this with the help of an example. Let's understand this. In Turner syndrome, chromosome number is 45XO. Now because Y chromosome is absent, so gonads will be ovaries, right? But then, because both X chromosomes are not present, because only one X chromosome is present, these ovaries will not function properly. And that is what is called as streak gonads. That is what is called as streak gonads. Neither will they function properly, neither will they form properly. So many times we have been listening to this, that in Turner syndrome there are streak gonads. So this is the reason why there is streak gonads in Turner syndrome, because they don't have both X chromosomes. So for proper development and for proper function of ovary, both X chromosomes are needed. Clear to all of you? These were the important points which you had to remember regarding development of gonads. Now, let's see how are the internal genital organs formed in male and female, right? Now, one very important thing which you have to remember is that in intrauterine life, in a fetus, in both males and females, in intrauterine life, both Wolffian duct and mesonephric duct are present. Mesonephric duct are present. So in intrauterine life, don't write it as mesonephric. It is the same thing, Mullerian, Wolffian and mesonephric. It's Wolffian and Mullerian duct. So in intrauterine life, in fetus, in both males and females, we have two pairs of ducts, and these two pairs of ducts are Wolffian duct and Mullerian duct. So there will be both Wolffian duct and Mullerian duct which will be present in males as well as in females. Now Wolffian duct The other name for Wolffian duct is mesonephric duct. So the other name for Wolffian duct is mesonephric duct, whereas the other name for Mullerian duct is paramesonephric duct. Paramesonephric duct. Right? So M and M are not together. Wolffian duct is called as mesonephric duct. Mullerian duct is called as paramesonephric duct. Mullerian is not mesonephric. Right? M and M are not together. So whether it's a male fetus or whether it's a female fetus, in both of them in early intrauterine life, both these ducts will be present. Right? Now, in males, what is going to happen? In males, the karyotype is 46XY. Congratulations, Ramakrishna. You have done really well in your FMGE. All the best. Now, I don't want you to stop here. I want you to clear your NEET PG also. Right? Okay. So, in males, karyotype is 46XY. Now, because there is Y chromosome, so gonads will be testes. Right? Now, testes has two types of cells, Sertoli cells and Leydig cells. Now, Sertoli cells, they are going to secrete anti-Mullerian hormone. Anti-Mullerian hormone, which is also called as Mullerian inhibiting substance. So, anti-Mullerian hormone AMH, or you can also call it as MIS, Mullerian inhibiting substance. So, I am telling you that testes has two types of cells, Sertoli cells and Leydig cells. Sertoli cells, they secrete anti-Mullerian hormone or Mullerian inhibiting substance. Now, this Mullerian inhibiting substance, as the name is suggesting, it is going to lead to regression of Mullerian duct in males. So, because of this Mullerian inhibiting substance secreted by the Sertoli cells, Mullerian duct is going to regress in males. Right? Now, when Mullerian duct regresses in males, there are certain remnants which are left in the males of Mullerian duct, and question is asked on this. What are the remnants of Mullerian duct in males? The remnant of Mullerian duct in males is prostatic utricle and appendix of testes. Prostatic utricle and appendix of testes. So, Mullerian duct's role was only up till here. Right now, Mullerian duct has regressed in males. Have you understood? Now, what is Leydig cells going to secrete? Leydig cells are going to secrete testosterone. So, testosterone in males is secreted by the Leydig cells. Now, what is this testosterone going to do? This testosterone is going to perform two functions. Number one, it is going to promote the growth of Wolffian duct. It promotes the growth of Wolffian duct in males. Right? And it is this Wolffian duct which is going to form the internal genital organs of male. And what are the internal genital organs of male? You can remember it by a simple mnemonic, SEED. S stands for Sertoli cells. E for S stands for seminal vesicles. S stands for seminal vesicles. E for epididymis. Another E for ejaculatory duct. and V for vas deferens. Seminal vesicles, epididymis, ejaculatory duct, and vas deferens. Right? Now comes the second role of testosterone. Second role of testosterone is testosterone with the help of enzyme 5-alpha reductase gets converted into dihydrotestosterone, DHT. And it is this DHT which makes the external genitalia look like male external genitalia. Right? So external genitalia resemble male external genitalia. They look like male external genitalia due to the presence of dihydrotestosterone. And this dihydrotestosterone is formed by testosterone. So testosterone is leading to two very important functions. Testosterone, which is secreted in intrauterine life by the Leydig cells of the testes, is going to promote the growth of Wolffian duct so that the internal genital organs are formed in male, and it is going to make the external genitalia look like male external genitalia. Till here it is clear to all of you? Now, one confuser which they give you. I told you that appendix of testes is a remnant of Mullerian duct. Now they are going to ask you, appendix of epididymis is formed by. Now, just because you look at this word appendix, you are in a hurry to mark the answer as Mullerian duct. Don't do that. I told you just now that epididymis is formed by Wolffian duct. So, appendix of epididymis is also formed by Wolffian duct. Right? So, that is a confuser which they give you, and so many times you people get confused with this question. Now, other important notes which I want you to remember. Just now I told you Sertoli cells in intrauterine life produces. So I told you Sertoli cells is producing anti-Mullerian hormone. So remember, it produces anti-Mullerian hormone plus it produces inhibin. And always, whenever inhibin is formed, the function of inhibin is to decrease FSH. Right? At puberty, Sertoli cells mainly forms inhibin. So in intrauterine life, it is going to form both anti-Mullerian hormone and inhibin. And at puberty, Sertoli cells will mainly form inhibin. Now, if your question comes, what is the first stimulus for the Leydig cells to produce testosterone? So many times in class I have repeated, one of the functions of hCG is that it is the first stimulus for Leydig cells to produce testosterone. Right? So the first stimulus for Leydig cells to produce testosterone in intrauterine life is hCG. It is not LH. Right? The next point where I want you to concentrate is, you people think that prostate gland in males is a part of internal genital organs. That's incorrect. Prostate gland in males is a part of external genital organs of males. Right? I hope these points are clear, and I hope how sexual development proceeds in males, that's clear to you. Yes? Now, if sexual development in males is clear to you, let's talk about sexual development in females. Now, in females, karyotype is 46XX. Right? Now, because Y chromosome is absent, so gonads will be ovaries. Right? Now, all of you know that ovaries have no Sertoli cells and no Leydig cells. Now, because ovary doesn't have Sertoli cells, So anti-Mullerian hormone will be absent. And this is happening in intrauterine life. So in intrauterine life in females, anti-Mullerian hormone is absent. And because anti-Mullerian hormone is absent, so Mullerian duct is going to grow. And when this Mullerian duct is going to grow in females, it is going to form the internal genital organs in females. So in males, the internal genital organ was formed by Wolffian duct. In females, the internal genital organ is formed by Mullerian duct. And what are the structures which are going to be formed by Mullerian duct? Number 1, fallopian tube. Number 2, uterus. Number 3, cervix. And number 4, upper part of vagina. Upper part of vagina. Right? So from where is the lower part of vagina formed? Lower part of vagina is formed by sinovaginal bulb. This sinovaginal bulb is a part of urogenital sinus. Urogenital sinus. Right? So it is better if the answer given is, if you have an option of sinovaginal bulb in the options, that is a better answer. If sinovaginal bulb is not given, then you are going to go for urogenital sinus. So upper part of vagina is formed by Mullerian duct. Lower part of vagina is formed by sinovaginal bulb, which is a part of urogenital sinus. Right? Now, in females, because there are no Leydig cells, so because there are no Leydig cells, so testosterone will be absent in intrauterine life. Testosterone is going to be absent in intrauterine life. And because testosterone is going to be absent in intrauterine life, so Wolffian duct regresses in females. And when Wolffian duct is going to regress in a female, again it is going to leave some remnants. Right? So what are the remnants of Wolffian duct in females? Another very important question. So number 1 is epioophoron. Number 2 is paraoophoron. Epioophoron, paraoophoron and Gartner's duct. Epioophoron, paraoophoron and Gartner's duct. These are remnants of Wolffian duct in females. Right? Now, because testosterone is absent, so obviously there won't be any dihydrotestosterone also. And when there won't be any dihydrotestosterone, so external genitalia look like female external genitalia. External genitalia look like female external genitalia. Is that clear to all of you? Yes. Now, one very important note which you have to remember, in intrauterine life in females, ovaries do not produce anti-Mullerian hormone and testosterone. But at puberty, it starts producing both. It starts producing both. So in intrauterine life, yes, anti-Mullerian hormone is absent in females and testosterone is absent in females. But the same ovaries, when they are going to reach the puberty, they are going to form both of them. Anti-Mullerian hormone will also be formed by a female, and androgens, that is testosterone, will also be formed by the female ovaries. Clear to all of you? Yes. Have you understood how internal genital organs are formed in males and in females? Now let's talk about formation of external genitalia. So one very important concept which you have to remember are the natural tendency of external genitalia is to form female external genitalia. Natural tendency is to form female external genitalia. Only if hormonal influence is present. Hormonal influence in the form of adequate quantities of testosterone and dihydrotestosterone in intrauterine life, then only male external genitalia will be formed. Right? So natural tendency in all babies, their external genitalia, their natural tendency is to look like female external genitalia. Only in intrauterine life, adequate quantities of testosterone and dihydrotestosterone are present, then male external genitalia will be formed. Is this clear to all of you till here? Yes? So if no hormonal influence is present in intrauterine life, then the natural tendency is to form female external genitalia. Now, the other concept which you have to remember is both testosterone and dihydrotestosterone, they act through same receptors. Both of them, their action is through same receptors. Right? Now, if you've understood my point that the natural tendency is to form female external genitalia, let us consider three conditions and see how are the external genitalia going to look like in those three conditions. Right? So, I want you to write this like this. So, suppose I have a 46XX individual, which as per genotype will be a female, right? And in this 46XX, there is no testosterone, no dihydrotestosterone. So if there is no testosterone, no dihydrotestosterone, natural tendency is that the external genitalia will be female-like. So they will have external genitalia female-like, right? Exactly like a female, and that's how it should be. If it is 46XX, their external genitalia should be a female external genitalia. And this is what is normal, right? Now suppose if in female there is some testosterone present in intrauterine life. Now, if there is some testosterone present in intrauterine life, now because testosterone and dihydrotestosterone, they act through same receptors. So, what is this some testosterone going to do? This some testosterone is going to make their external genitalia resemble a male genitalia. It will not be a look-alike. It will not exactly look like male external genitalia, but there will be resemblance to male external genitalia. So the female external genitalia starts resembling male genitalia. Male external genitalia, right? And this is what is called as ambiguous genitalia. This is what is called as ambiguous genitalia, right? Now, normal genitalia in a female is external genitalia, in a female is clitoris, right? Then we have labia majora. I am talking only about the most important ones, and labia minora. Now, when there is testosterone present, clitoris starts resembling a penis, right? And that is what is called as clitoromegaly. So you will get clitoromegaly, right? So you will not understand whether you are looking at a clitoris or whether you are looking at a penis, because there is something in between. Neither it is as small as a clitoris, neither it is as big as a penis, right? It is somewhere in between, and that is what is called as clitoromegaly, and that is what is ambiguous genitalia. Then labia majora and labia minora, they will be fused. There will be fusion of labia and they will resemble scrotum. They will start resembling scrotum, right? So this is what is ambiguous genitalia, where it is not a clear-cut labia majora, labia minora. It is not a clear-cut scrotum. There is something in between. Are you understanding? And this is going to happen when in females there is some testosterone present in intrauterine life. And when is this some testosterone present in intrauterine life? This is seen in congenital adrenal hyperplasia. This is seen in congenital adrenal hyperplasia. Right? So if I ask you what is the most common cause of ambiguous genitalia in females? Ambiguous genitalia in females, you are going to say it is congenital adrenal hyperplasia. In congenital adrenal hyperplasia, testosterone is present in females in intrauterine life. Are you understanding this? Now let's talk about 46XY, normal and abnormal, right? So if I have an individual with 46XY chromosome, karyotyping is 46XY. Now 46XY means that they are males according to their genotype. Now in this 46XY, if testosterone is present adequately and dihydrotestosterone is present adequately, then their external genitalia will be male external genitalia, right? Only if testosterone is present adequately and if dihydrotestosterone is present adequately, then it will be male external genitalia, right? Now, what are male external genitalia? Penis, scrotum, and penile, urethra, prostate. All these are your male external genitalia. We are concentrating only on penis and scrotum. Now, suppose if individual is 46XY and they are testosterone is present but not adequately. Testosterone present hai, but it is not present adequately, or these males are partially sensitive to testosterone. these males are only partially sensitive to testosterone. So if they will be partially sensitive to testosterone, they will be partially sensitive to dihydrotestosterone because both of them act through the same receptors. So if they are partially sensitive to testosterone, or if testosterone is present but it is not adequately present, in this case, the external genitalia of male starts resembling female external genitalia. It starts resembling female external genitalia. Right? And this is what is called as ambiguous genitalia. This is what is called as ambiguous genitalia. So when there will be testosterone present but not adequately, so the penis is not going to be of its normal length. There will be something like a micro penis. So ambiguous genitalia includes micropenis. Ambiguous genitalia includes hypospadias. All these are included in ambiguous genitalia. So if they say there is clitoromegaly, it means there is ambiguous genitalia. If they say there is labioscrotal fusion, then there is ambiguous genitalia. If they say there is micropenis, it indicates ambiguous genitalia. If your question says hypospadias is present, again it indicates ambiguous genitalia. Right? Now the most common cause of ambiguous genitalia in males. So ambiguous genitalia का most common cause in males is partial androgen insensitivity syndrome. Partial androgen insensitivity syndrome. Normally we just say androgen insensitivity syndrome, but do not say that's an incomplete answer. The correct complete answer is partial androgen insensitivity syndrome. Right? Now imagine a male in whom testosterone is absent. Testosterone is completely absent. Right? Or they are completely resistant to testosterone. Now, if males are completely resistant to testosterone, their external genitalia will look exactly like female. Their external genitalia will look exactly like female. And this is what happens in complete androgen insensitivity syndrome. So in partial androgen insensitivity syndrome, the external genitalia will resemble a female external genitalia. But in complete androgen insensitivity syndrome, as I told you, that if there is no hormonal influence, just now we did, if there is no testosterone, no dihydrotestosterone, the external genitalia will be exactly female. Same thing happens here. In complete androgen insensitivity syndrome, they are completely insensitive to testosterone and to dihydrotestosterone. So the external genitalia will look exactly like a female. And that is why I said that if they ask you what is the most common cause of ambiguous genitalia in males, the answer should be partial androgen insensitivity syndrome. Complete androgen insensitivity syndrome may we take it that this is a female child, although the chromosome number is 46XY. But when as a gynecologist we are going to look at the genitalia, we are going to get exactly the same genitalia. And we are going to say designate the sex as a female sex, although the chromosome number would be 46XY. But if I am getting exactly female genitalia, I will never be in doubt. Right? If I am in doubt, if I am getting ambiguous genitalia, then I do karyotyping. When I see exactly female genitalia, we are not in doubt. We think that yes, it is a female baby and we designate the sex as female. Is this clear to all of you? Any confusions here? Any confusions? Or is it all clear? I'm just waiting for a quick thumbs up so that I can proceed ahead. Quickly show me a thumbs up if all of you have understood this. Show me a thumbs up. I'm just waiting. Okay. Now, what are homologous organs? Homologous organs. Homologous organs are those organs in males and females which have same embryological origin. Which have same embryological origin. Sahiba Yunus, you are saying, ma'am, it's not clear. Are you a student from Bishkek, Sahiba? If you are a student from Bishkek, come to me after the class, after the offline class. I'll explain whatever you've not understood. Right? But it was once you go through this lecture again, I'm sure you will understand. Still, if you don't understand, and if you are a student of Bishkek, today after the offline class, you can come and meet me and I'll explain you again. So these homologous organs are those organs in males and females which have same embryological origin, right? So write down embryological structure. So then, Sahiba, when you will listen to the lecture again, you will understand embryological structure, males and in females. So embryological structure is genital tubercle. Genital tubercle, it forms penis in males, clitoris in females. So penis and clitoris are homologous organs. Genital swellings. Genital swellings, they form scrotum in males, labia majora in females. Then we have genital folds which form penile urethra in males and labia minora in females. So penis and clitoris are homologous structures, scrotum and labia majora are homologous structures, and penile urethra and labia minora are homologous structures. Two more structures which you have to remember which are homologous are prostate gland in males. It is homologous to skein glands or paraurethral glands in females. Paraurethral glands in females, whereas Cowper's gland in male. Cowper's gland is also called as bulbourethral gland. So Cowper's gland or bulbourethral gland in males is homologous to Bartholin glands in females, right? So these are homologous organs and you get a direct question from homologous organs. Now my next question to you is, suppose you have a baby who's born with ambiguous genitalia. So what is the first step which you are going to do when you see a baby with ambiguous genitalia? So whenever a baby is born with ambiguous genitalia, and if you get a question, what is the next step or the first step which you have to do when a baby is born with ambiguous genitalia, do not say karyotyping. First step is physical examination. First step is physical examination. I am going to physically examine the baby, and then the best step is, so you have to do a physical examination of the external genitalia, and the best step is karyotyping. Karyotyping, right? So first step, or immediately when you see ambiguous genitalia, the next step is you have to do a thorough physical examination. And if they ask you what is the best step to be done when a baby is born with ambiguous genitalia, the best step is karyotyping. Clear to all of you? So have you understood what are ambiguous genitalia, how is normal sexual development proceeds, how an abnormal sexual development proceeds? Now, if you've understood this much, just one more thing which you have to understand before I go to primary amenorrhea, and that is secondary sexual characteristics. Now, secondary sexual characteristics, they are going to develop at puberty. Secondary sexual characteristics develop at puberty. In females, the most important secondary sexual characteristic is breast development. Breast development, which is called as thelarchy. And breast in a female develops due to the hormone estrogen. The hormone responsible for breast development is estrogen. Apart from breast, the two other secondary sexual characteristics are axillary hair and pubic hair. This is called as pubarchy. And in females, as I told you, from puberty onwards, ovaries start producing androgens. And for development of pubic hair and axillary hair, a female does not need estrogen. A female needs androgens. So pubic hair and axillary hair in a female also, for their development, androgens are needed. Right? And this is the reason why ovary starts producing androgens from puberty onwards. Right? For breast development, estrogen. For pubic hair and axillary hair development, androgens. Right? Now, in males, secondary sexual characteristics, again, they are axillary hair, pubic hair, increased muscle mass, deepening of voice. These are secondary sexual characteristic in males. And for secondary sexual characteristic in males, the hormone which is needed is androgens, that is testosterone. Clear? So in females, for breast, it is estrogen. For pubic hair and axillary hair, it is androgens. In males, for secondary sexual characteristics, androgens. The other important point is, in females, breast development and pubic hair development, it doesn't happen suddenly. It happens in stages. And this staging was given by Tanner, and it is called as Tanner staging. So for breast development and pubic hair development, we have something which is called as Tanner staging. You don't need to remember the entire stage. You simply have to remember that in Tanner staging, there are 5 stages, right? 1, 2, 3, 4, 5. If your question says that breast development or pubic hair development corresponds to Tanner stage 1 or 2, तो Tanner stage 1 or 2 का मतलब है early development, right? So it's very immature looking breast or immature looking pubic hair, right? So it's immature breast or pubic hair. But if someone has breast or pubic hair corresponding to Tanner stage 4 and 5, that means it's a mature breast or mature pubic hair, right? Properly developed, fully developed, mature breast or mature pubic hair, Tanner stage 4 or 5. Clear to all of you? Any confusion still here? Any confusions? If no confusions, now I'm going to proceed with amenorrhea, right? Quickly show me a thumbs up so that I come to know that there are no confusions. Now, I'm waiting for your thumbs up. Show me a thumbs up quickly. Shashi Bhushan, thank you for responding that everything is clear. Rest clear to all of you? Yes? Rupesh, stage 3 is in between, right? So it is neither mature breast, it is neither immature. So in your question, never they are going to ask you like this, that stage 3 breast development. Either they are going to say stage 1 or 2, or they are going to say stage 4 or 5, right? Now coming to amenorrhea. Amenorrhea could be primary or it could be secondary. Amenorrhea simply means absence of menstruation. Absence of menstruation. Now there could be primary amenorrhea and secondary. Om Prakash, let me come to androgen insensitivity syndrome and you will understand everything. Don't worry. Right? Just let me come to it. So, amenorrhea can be primary or it could be secondary. Primary amenorrhea means no menarche by 13 years of age in absence of secondary sexual characteristics. Right? And what is the secondary sexual characteristic? As I told you, breast development. So in absence of breast development, if there is no menarche by 13 years of age, then we say it is primary amenorrhea, or by 15 years of age in presence of secondary sexual characteristics. That means in presence of breast. So if in a female breast is absent and she has not had menarche by 13 years of age, that is primary amenorrhea. Or if breast is present and she has not had menarche by 15 years of age, that is primary amenorrhea, right? Now, most common cause of primary amenorrhea is gonadal dysgenesis. That is the best answer to mark. Most common cause of primary amenorrhea is gonadal dysgenesis. Gonadal dysgenesis is of 3 types. Gonadal dysgenesis is number 1, Turner's syndrome, which is 45XO, and in gonadal dysgenesis, the most common variety is Turner's syndrome, right? Then it could be XY type, that is Swyer's syndrome, or it could be XX type. So gonadal dysgenesis is of 3 types. Turner's syndrome, 45XO, XY gonadal dysgenesis, which is called as Swyer's syndrome, and XX gonadal dysgenesis. Now, amongst all the 3 varieties of gonadal dysgenesis, the most common is Turner's syndrome. So, in your question, if you get a question that most common cause of primary amenorrhea and in the options you have gonadal dysgenesis, that is the best answer. But suppose if gonadal dysgenesis is not given, then you are going to mark your answer as Turner's syndrome. But if Turner's syndrome is also not given, then you are going to mark your answer as Mullerian agenesis. So for primary amenorrhea, write down best answer is gonadal dysgenesis. Second best answer is Turner's syndrome. And if that is also not given, then third best answer is Mullerian agenesis. So because Turner's syndrome is a part of gonadal dysgenesis, we say that the most common cause is gonadal dysgenesis and the second most common cause is Mullerian agenesis. But answer wise, best answer is gonadal dysgenesis, second best answer is Turner's syndrome, and third best answer is Mullerian agenesis. Are you understanding this? Third best answer, Mullerian agenesis. So if someone asks you what is the most common cause, you are going to say gonadal dysgenesis, and the person should understand that in gonadal dysgenesis, Turner's syndrome is included. And the second most common cause is Mullerian agenesis. But if any one of your friend doesn't understand this, you are going to say answer mark karna hai, to best answer is gonadal dysgenesis. Gonadal dysgenesis options mein nahi diya hai, then Turner's syndrome, and if Turner's syndrome is also not given in options, then Mullerian agenesis. Clear to all of you? Yes. Now coming to secondary amenorrhea. What is secondary amenorrhea? Secondary amenorrhea is absence of menstruation for 3 cycles. 3 cycles if female was regularly menstruating. If her menstrual cycles were regular, then if she doesn't have any if she is missing her periods for 3 cycles, I'm going to say secondary amenorrhea. Or for 6 months. Now 6 months means if she had irregular cycles. So I'll explain you with an example. Suppose I have 2 patients. One female who was having regular menstrual cycles, and she says that doctor, normally I used to have regular menstrual cycles, and for past 3 months I didn't have my periods. That is secondary amenorrhea. But all of you know, in patients of PCOS, cycles are irregular. Sometimes cycle comes in 2 months, sometimes in 3 months. In such a case, if she was having irregular cycles, if she comes and says to me that for past 6 months she did not have her periods, then I'm going to say it is a case of secondary amenorrhea. So in irregular cycles for 6 months, in regular cycles for 3 regular cycles, if periods don't happen, that is secondary amenorrhea. And I'm sure all of you know the most common cause of secondary amenorrhea, that is pregnancy. Pregnancy is the most common cause of secondary amenorrhea. Clear to all of you? Yes, the definition part. Now comes very, very important algorithm. Whenever they give you a question of primary amenorrhea and they ask what is the next step, immediately karyotyping pe nahi jaoge. Right? Primary amenorrhea ke patients mein you are not going to say that immediately the next step is karyotyping, although best is karyotyping. In a patient of primary amenorrhea. Why is best karyotyping? Because most common cause is gonadal dysgenesis. Right? And gonadal dysgenesis mein I told you most common is Turner's, in which chromosome number is 45XO. And then I told you next most important cause is Mullerian agenesis. And Mullerian agenesis chromosome number is 46XX. So because the chromosome numbers are different in the karyotype is different in Turner's and Mullerian agenesis. So obviously best investigation or the confirmatory test for primary amenorrhea is karyotyping. But it is not the first step. Whenever a patient of primary amenorrhea comes to you, first step is physical examination. In physical examination, you are going to look at the breast development and external genitalia of the female. Then you are going to do a urine pregnancy test. Now you're going to say, ma'am, primary amenorrhea, maybe do we do a urine pregnancy test? Because pregnancy is the most common cause of secondary amenorrhea. See, in primary amenorrhea also you will have to do a urine pregnancy test, because sometimes you will get cases of incest. And in cases of incest, they would have conceived immediately as they would have attained their menarche. So in rare cases, a patient of primary amenorrhea could also be pregnant. Right? So in primary amenorrhea also I have to do a urine pregnancy test. Then I am going to go to the ultrasound. In ultrasound, I am going to look at the gonads and I am going to look whether uterus is present or not. And then I have to get FSH levels checked. Right? So this is the algorithm which you have to follow in primary amenorrhea. You have to do a physical examination. After physical examination, go for a urine pregnancy test, get an ultrasound done and FSH levels tested. Right? In physical examination, look at the breast and external genitalia. On ultrasound, look at the gonads and the uterus. And then check the FSH levels. Now, if they ask you what is the best investigation or confirmatory test for primary amenorrhea, confirmatory test for primary amenorrhea is karyotyping. Clear? Confirmatory test is karyotyping. Now, coming to causes of primary amenorrhea. So first tell me, have you all understood till here? If you've understood, I'll proceed to the causes of primary amenorrhea. Now, causes of primary amenorrhea. In order to enlist and remember the causes of primary amenorrhea, you will have to understand that why menstruation happens. See, menstruation happens because hypothalamus releases GnRH. GnRH acts on anterior pituitary, and from anterior pituitary, LH and FSH is released. Then FSH is going to act on the ovary and produce estrogen, and LH brings about ovulation and produces progesterone. Both these estrogen and progesterone, they act on the uterine endometrium. Estrogen endometrium को proliferate कराता है, progesterone endometrium को support करता है. And then levels of both estrogen and progesterone are going to fall down. And because the levels of progesterone falls down, then it leads to menstruation. Now, for menstrual bleeding to appear, we need outflow tract should be normal. The place from which menstruation is happening, that should be absolutely normal. Right? So this means for a female to menstruate, there should be normal hypothalamus, there should be normal pituitary, there should be normal ovary, there should be normal uterus, and there should be a normal outflow tract so that menstrual blood comes out easily. Right? If there is a problem in any of these, चाहे वो हाइपोथैलेमस की प्रॉब्लम हो तो भी पेशेंट को मेंस्ट्रुएशन नहीं होगा, एंड दैट इज प्राइमरी एमेनोरिया. अगर पेशेंट में पिट्यूटरी की प्रॉब्लम हो या ओवरी की प्रॉब्लम हो या यूट्रस की प्रॉब्लम हो, एनी प्रॉब्लम इन एनी ऑफ दीज ऑर्गन्स is going to lead to amenorrhea. Right? So what problem in hypothalamus can lead to primary amenorrhea? Causes of primary amenorrhea. So what problem in hypothalamus leads to primary amenorrhea? It is Kallmann syndrome. Kallmann syndrome is a problem of hypothalamus which leads to primary amenorrhea. Problem in pituitary which leads to primary amenorrhea is craniopharyngioma. Problem in ovary which leads to primary amenorrhea is gonadal dysgenesis. Gonadal dysgenesis is Turner's syndrome, that is 45XO. It can be Swire's syndrome, that is 46XY, or it could be 46XX gonadal dysgenesis, in which the most common and what you have to study in detail is Turner's syndrome, right? Then a problem in uterus which can lead to amenorrhea, primary amenorrhea, is number 1, Mullerian agenesis, and number 2, androgen insensitivity syndrome. Androgen insensitivity syndrome. Mullerian agenesis is 46XX. Androgen insensitivity syndrome is 46XY. A problem in outflow tract which leads to amenorrhea is cryptomenorrhea. I am writing it here so that you can see. Cryptomenorrhea. Cryptomenorrhea. Excuse me. So now we are going to talk about each of these causes. So causes of primary amenorrhea are Kallmann syndrome, then craniopharyngioma. Craniopharyngioma you are taught in pediatrics, you are not taught in OBGY. So Kallmann syndrome, gonadal dysgenesis, in which we have to study Turner's syndrome in detail. Then Mullerian agenesis and androgen insensitivity syndrome, and a problem in outflow tract, that is cryptomenorrhea. So starting from the first cause, and that is Kallmann syndrome. Kallmann syndrome में females का genotype is normal. The genotype is 46XX. Now because they are 46XX, so gonads will be ovary, right? Now because they are 46XX, so internal genital organs will be normal. In other words, uterus is present, and because everything is normal with relation to sexual development, so external genitalia will also be females. Everything is normal in these females. There is no excessive androgen production, nothing. In intrauterine life, everything is happening normally in them. Right? They are, in intrauterine life, they are a normal female, right? Which have 46XX chromosome, where the internal genitalia are normal, the external genitalia are normal, gonads are normal, right? Everything is normal in them, right? Now, what is the problem? Problem is that at puberty, hypothalamic failure occurs. Right? There is hypothalamic failure. Now, because there is hypothalamic failure at puberty, what is going to happen? There will be decreased GnRH. Right? And because there will be decreased GnRH, there will be decreased LH and decreased FSH. And because there will be decreased LH and decreased FSH, there will be decreased estrogen. Now, obviously, अगर किसी female में there is decreased GnRH, decreased LH, decreased FSH, so there will be primary amenorrhea. She will not menstruate. So, at puberty, the hypothalamic pituitary axis did not get mature. At puberty, there is failure of hypothalamic pituitary axis. So, the levels of GnRH are less, LH is less, FSH is less, estrogen is less. Now, because at puberty the levels of estrogen is less, so for development of breast, what was needed? For development of breast, estrogen was needed, right? And because estrogen levels are less, so there will be secondary sexual characteristics will be absent. In other words, breast development will be absent. right? Intrauterine life में everything was normal in them. There was no problem in their sexual development in intrauterine life. At the time of puberty, the problem which has happened is that their hypothalamic pituitary ovarian axis, which had to mature, it didn't mature, right? So now at puberty, they don't have GnRH, no LH, no FSH, no estrogen. Obviously, if there is no LH, no FSH, no estrogen, they will have primary amenorrhea and their secondary sexual characteristics will be absent. Also, they may come to you with complaint of infertility in later life. In later life, they are going to come to you with complaint of infertility also, right? Now, height of the patient will be absolutely normal. The additional feature which you get in Kallmann syndrome, which helps you to know that yes, this is Kallmann syndrome, is anosmia. They have absent smell sensation. They have absent smell sensation. Now, Kallmann syndrome can be seen in males and females both. Right? This is a problem which could be seen in males and females both, and it is more common in males than it is in females. Now, in gynae, the funda is very simple. Whatever is missing, give that as the treatment. So, in Kallmann syndrome, the missing thing was absent GnRH. Because GnRH was absent, so everything else was absent, right? So, if I have to treat this patient, what am I going to give? I am going to give GnRH. And how am I going to give GnRH? I am going to give GnRH like it is normally secreted in a female body, and normally GnRH is secreted in a pulsatile manner. So I am going to give GnRH in a pulsatile manner. When I will give GnRH in a pulsatile manner, her problem will be over. Clear to all of you? Have you understood Kallmann syndrome? So in Kallmann syndrome, there was no problem in intrauterine life. Problem begins when the hypothalamic pituitary axis had to mature. It did not mature, and that led to decreased GnRH, decreased LH, decreased FSH, primary amenorrhea, and it led to absent breast development. Patient may come to you with complaint of infertility, and along with that there will be anosmia. That's a very, very typical feature of Kallmann syndrome, right? Now comes gonadal dysgenesis. Gonadal dysgenesis means the gonads are not functioning properly. So in all patients of gonadal dysgenesis, secondary sexual characteristic, that is breast, will be absent, right? Because the gonads are not functioning properly, so the levels of estrogen will be less. And if levels of estrogen are less, the negative feedback on FSH is lost. So the levels of FSH will be high and levels of LH will also be high. Right? Are you seeing this? In Kallmann syndrome, the levels of LH and FSH were less. And that is why I told you, in all patients of primary amenorrhea, you have to get FSH levels done. Because based on FSH levels also, I can come to know whether I am dealing with Kallmann syndrome or whether I am dealing with Turner's syndrome. So in gonadal dysgenesis, the levels of LH and FSH are high. Right? And in all these cases, uterus will be present. That's a common feature of all gonadal dysgenesis. Secondary sexual characteristics are absent because they have decreased estrogen. Because they have decreased estrogen, the negative feedback on LH and FSH is gone. So there will be increased LH and increased FSH. And uterus will be present in all these patients. Now, let us talk about Turner's syndrome and understand. Rahul, what is leuprolide? Tell me, what is leuprolide? Quickly write to me, what is leuprolide? So in the meanwhile, while Rahul is writing what is leuprolide, we will talk about Turner's syndrome. Turner syndrome is 45XO, right? Now, because it is 45XO, Rahul, abhi aane do Turner syndrome. Yes, abhi I taught you that in gonadal dysgenesis, and gonadal dysgenesis का most common cause होता है Turner syndrome. So in gonadal dysgenesis, that is Turner syndrome, LH and FSH will be high. And Kallmann syndrome mein just now I told you LH and FSH will be low. So let me come to Turner syndrome, you will understand. So Turner syndrome is 45XO. Now because Y chromosome is absent, so the gonad will be ovary, but this will be a streak gonad. Why? Because there is only one X chromosome present. Because only one X chromosome is present, so although the gonads are ovary, they will be streak gonads, right? So they will not grow properly, the ovaries will not go properly, and that is what is called as streak gonads, right? So if you want to write it, you can write it like this in the flowchart form. Because Y chromosome is absent, so the gonad is ovary, but these ovaries will not grow properly, they will be streak gonads because only one X chromosome is present. Now obviously if the ovaries are not growing properly, there will be decreased estrogen, and because there will be decreased estrogen, their secondary sexual characteristics will be absent. Breast development will be absent. And that is why I told you in all females with gonadal dysgenesis, breast development is absent, right? Now in patients में there is no problem with their testosterone secretion. Testosterone कुछ नहीं हो रहा है. I am not saying that in intrauterine life testosterone is getting increased. No, testosterone is not getting increased. Everything is normal in intrauterine life. The problem is that the ovaries are not functioning properly. Right? So if ovaries are not functioning properly, there will be less estrogen at the time of puberty. In intrauterine life, there is no role of ovaries. There is no role of estrogen. In intrauterine life, role is of absence of testosterone. जब absent testosterone होता है in females, so the external genitalia look like females. So in females में everything is normal, right? Everything is normal. That is, there is no increased testosterone. There is no increased testosterone, right? And because there is no increased testosterone, so their external genitalia will be females and their internal genitalia will also be females because Mullerian duct grow karega. Everything is normal otherwise, right? Only problem is that this ovary is not functioning properly. And if ovary is not functioning properly, it is not producing estrogen properly. So at puberty, the breast development is not happening, right? I am not saying कि in intrauterine life there is more testosterone. There is no more testosterone. कुछ नहीं हो रहा है. Testosterone से related कोई problem नहीं हो रही है, right? And अगर testosterone से related कोई problem नहीं हो रही है, तो external genitalia has to be female external genitalia, right? And internal genitalia has to be female also, right? So in Turner syndrome, uterus, if I ask you internal genitalia क्या होगा? You are going to say internal genitalia will be females, right? So uterus will be present. Uterus will be present. So that is why I told you जितने भी gonadal dysgenesis के patients होते हैं, उनमें secondary sexual characteristics absent होती हैं, uterus present होता है. The only thing which you have to keep in mind is estrogen is needed for the growth of uterus. So in these patients, uterus is present, but उसका size छोटा होता है. It is infant-like. And infant-like के लिए term होता है infantile uterus. Right? So uterus is present, but the size of the uterus is small, right? Then in these females, there is a mutation in gene called as SHOX gene. Because of the mutation in SHOX gene, they have short stature, right? Now, because their ovaries are not functioning properly, so there will be decreased estrogen, and so the negative feedback on FSH will be lost, so levels of FSH will increase. And because their ovaries are not functioning properly, so there is no ovulation, and if there is no ovulation, there will be decreased progesterone, and progesterone has a negative feedback on LH, so that negative feedback on LH will be lost, so there will be increased LH. That is why I told you in patients of gonadal dysgenesis, there will be increased LH and increased FSH. Right? Yes, you are right, Rahul. Infantile uterus is also called as hypoplastic uterus. Are you understanding this? So what happened in Turner's syndrome? In Turner's syndrome, karyotype is 46XO. Because karyotype is 46XO, Y chromosome is absent, so the gonads will be ovaries, but because only one X chromosome is present, that is why the gonads will be streak gonads, right? So these streak gonads will form less estrogen at the time of puberty, because of which there will be absent secondary sexual characteristics, and they will have mutation in SHOX gene, which is going to lead to short stature. And because the ovaries are not functioning properly, so estrogen is less, so negative feedback on FSH goes, so that there are increased FSH levels. And because there is no ovulation, so there is decreased progesterone, and that is going to lead to increase in LH levels. Now, in females में intrauterine life में there is no exposure to testosterone. Everything is normal with respect to testosterone in intrauterine life. राइट ऐसा नहीं होता कि इनमें एक्सपोजर होता है टेस्टोस्टेरॉन का. देयर इज नो एक्सपोजर, एंड इफ देयर इज नो एक्सपोजर ऑफ टेस्टोस्टेरॉन, देन the internal genital organs will be female, that is uterus, and external genital organs will also be female. Now, only thing is that uterus needs estrogen for its proper growth. So although uterus will be present, but it will not grow very properly, right? And that is a hypoplastic uterus or an infantile uterus. Apart from this, in Turner's syndrome, you get many additional features. Once this session is over, I want all of you to copy these features. These are webbing of neck, low posterior hairline, widely spaced nipple, shield-shaped chest. So you are going to copy all these additional features of Turner's syndrome, right? Now, if I ask you what is the management of Turner's syndrome, as I told you in gynae, whatever is deficient, wo de do. So over here, what was the problem? The problem was in the ovary and estrogen was deficient. So I am going to give estrogen to the patient, right? Why I am giving estrogen to the patient? So that breast development happens. Now, all of you know that whenever uterus is present, and if you give estrogen alone, it results in endometrial cancer. So I am going to give estrogen to the patient for breast development for 1 year, and then I am going to give estrogen plus progesterone, right? Because if I give estrogen alone, it is going to result in endometrial cancer. And for short height, I will have to give growth hormone. Clear to all of you? Yes, whenever you are giving estrogen or whenever you are giving estrogen and progesterone, that is what is HRT, hormone replacement therapy. Now look at this question, a very interesting question. In Turner's syndrome, all of the following are true except option A, streak ovaries should be removed surgically due to 25% chances of their turning malignant. Option B, there is increased FSH levels. Option C, female external genitalia. Option D, they have normal but infantile internal genitalia. So I have told you, yes, option D is correct. They have external genitalia which is female-like. Their FSH levels are increased. So by exclusion also the answer becomes option A, and you have to remember, streak ovaries should not be removed. Streak ovaries do not have any chances of malignancy. I will tell you one condition in which testes are intra-abdominal. Intra-abdominal testes should be removed because they have chances of malignancy. Streak ovaries में कोई chances नहीं होते हैं malignancy के, and they should not be removed. Clear? So, case 1. Case 1 is, you get a question where there is a patient with primary amenorrhea with uterus present. There is a patient who has primary amenorrhea with uterus present with absent secondary sexual characteristics. Right? So question में आया है primary amenorrhea का patient है, uterus present है and secondary sexual characteristics absent है. So just now we saw that both in Kallmann syndrome and in Turner syndrome, in both these conditions, uterus was present, but secondary sexual characteristic was absent, right? And दोनों में differentiate करने के लिए, I told you, you have to look at LH-FSH levels. So in your question, look at the LH-FSH levels. अगर LH-FSH levels low दिए हैं, that means we are dealing with Kallmann syndrome. In Kallmann syndrome, height of the patient will be normal and additional features जो कि Turners में present होते हैं, वो Kallmann में absent होते हैं. The question will never say that there is webbing of neck, there is posterior hairline, there is all these features. Widely spaced nipple, shield shaped chest. कभी भी question में ऐसा कुछ mention नहीं होगा. Simply question में दिया होगा height of the patient is normal, LH and FSH levels are decreased. But if LH and FSH levels are increased, it means we are dealing with gonadal dysgenesis. Gonadal dysgenesis में अगर 45XO है, then it means it is Turner's syndrome. And gonadal dysgenesis में अगर chromosome number 46XY है, that means it is Swyer's syndrome. In Turner's syndrome, height of the patient is short. In Swyer's syndrome, height of the patient is normal. Swyer's के बारे में you don't have to know much details as an FMG student. Yes, please remember कि ये जो भी यहाँ पे है, I told you, cardiovascular anomalies which you get in Turner's syndrome. They are bicuspid valve and coarctation of aorta. This is the answer to meet what you are asking. Now, because Turner's syndrome में coarctation of aorta एक बहुत important complication है, and coarctation of aorta में pregnancy is contraindicated. That is why Turner's syndrome के patient में भी pregnancy is a relative contraindication. Right? Because patients of Turner's syndrome have coarctation of aorta or bicuspid aortic valve. Clear? Is this clear to you? That if a patient is coming to you with primary amenorrhea, with uterus present and absent secondary sexual characteristics, there are only two differential diagnoses which you have to think about. Kallmann and gonadal dysgenesis. So question में देखो, what are the levels of LH and FSH given? If LH and FSH are low, it means you are dealing with Kallmann. If LH and FSH are high, it means you are dealing with gonadal dysgenesis. Gonadal dysgenesis में अगर karyotype 45XO दिया है या दिया है कि patient का short stature है, that means you are dealing with Turner's syndrome. अगर 46XY दिया है and patient's stature is normal, then you are dealing with Swyer's syndrome. Right? Now comes a case 2. Case 2 is if they give you a question where you get primary amenorrhea with uterus present and secondary sexual characteristics are also normal. Now you are not going to think about Kallmann or Turner's. Now you are going to think about cryptomenorrhea. Right? In cryptomenorrhea, there will be uterus will be present, secondary sexual characteristics will be normal. Now, cryptomenorrhea means a female menstruates normally. A female menstruates normally, but menstrual blood fails to come out. Menstrual blood fails to come out due to some obstruction in the outflow tract. Due to some obstruction in outflow tract. And that obstruction can be imperforate hymen, or it can be a transverse vaginal septum. Transverse vaginal septum. Right? So, if this is the vaginal introitus, that is the vagina's opening, in the vaginal introitus, there is a thin membrane present which is called as hymen, which covers this vaginal introitus. Normally in this hymen, a small hole is present, an opening is present through which menstrual blood comes out. Right? So this is normal. Suppose if you have a vaginal opening in which the entire opening is closed by hymen and there is no opening for menstrual blood to come out. That is what is called as imperforate hymen. Imperforate hymen. Right? Now, if there is imperforate hymen, the entire opening of the vagina is closed by a thin membrane. Obviously, menstrual blood will not be able to come out and female will present to you as a case of primary amenorrhea. Such amenorrhea is given a typical name and that typical name is cryptomenorrhea. Right? Now, what will be the karyotype in these females? ये females बिल्कुल normal females हैं. सब कुछ normal है. The only problem is that hymen doesn't have an opening. So, the karyotype is 46XX. Gonads are ovaries, and because ovaries are absolutely normal, so estrogen will be normal. So, secondary sexual characteristics will be normal. Their HPO axis is normal. Their LH and FSH is normal. Everything is normal in these females. The only problem is obstruction in outflow tract. Right? So they are absolutely normal females with absolutely normal secondary sexual characteristics, absolutely normal uterus, कोई problem नहीं है इन patients में, right? In terms of development. So the uterus is also normal. Everything is normal. External genitalia is female genitalia. सब कुछ normal है इन females में, right? Only problem is that there is an obstruction in the outflow tract because of which menstrual blood is unable to come out. Clear? Okay. Now, this female, how is she going to present to me? This female is going to come to me and she is going to complain that every month she has cyclical pain in abdomen. Every month she has cyclical pain in abdomen, but there is no menstruation. Right? This, because there is no menstruation, what is actually happening in these females? In these females, blood is getting collected in vagina, cervix, and ultimately in uterus. So blood is going to get collected in vagina, cervix, and ultimately in uterus. When blood collects in vagina, that is called as hematocolpos. When blood collects in cervix and vagina, that is hematocolpros. When blood collects in uterus, that is hematometra. Right? Now, due to hematometra, due to the large size of the uterus, they may complain of urinary retention. It could be that the uterus enlarges and it in the pelvis, when it is going to enlarge, it is going to press on the urethra, and these females may come to you as a complaint of urinary retention. It could be कि uterus इतना बड़ा हो जाए, the uterus becomes so big that per abdominally uterus may be palpable. It may be palpable due to hematometra. Now, please remember, you are never going to do per vaginal examination in a virgin female, right? So, if the uterus is not palpable per abdominally and I want to check the size of uterus per vaginally, I am not going to do a per vaginal examination. I am going to do a per rectal examination to see the size of the uterus. So if I want to look at the size of the uterus, I am not going to do a per vaginal examination in a virgin female. I am going to do a per rectal examination, right? And when you will do local examination, you will see there is tensed, bluish, bulging hymen. You will get tensed, bluish, bulging hymen. Management is you have to give a cruciate incision on the hymen. Whatever blood will be collected, it is going to come out, and from next time onwards, she will menstruate normally, right? So on local examination, you get a tensed, bluish, bulging hymen, and management is cruciate incision on the hymen. So this is how a tensed, bulging hymen looks like, right? Now if I want to differentiate between transverse vaginal septum and imperforate hymen, how am I going to do it? So first understand what is a transverse vaginal septum. See, upper part of vagina, the upper part of vagina is developing from Mullerian duct, right? And lower part of vagina, it develops from urogenital sinus. Now both these parts, they are going to fuse and a transverse vaginal septa is formed. So upper part, which is formed from Mullerian duct, lower part is formed from urogenital sinus. Ultimately, both of them are going to fuse and a transverse vaginal septa is formed, which normally resolves by 20 weeks. But if this septa fails to resolve, then you get a transverse vaginal septum. And obviously, if there is a transverse vaginal septum, menstrual blood will not be able to come out. And so, although most common cause of imperforate hymen is, most common cause of cryptomenorrhea is imperforate hymen, but you may get transverse vaginal septa also as a cause of cryptomenorrhea, right? Now, most common site for presence of transverse vaginal septa is upper 1/3 of vagina. Presentation of transverse vaginal septa will be same like imperforate hymen. How am I going to differentiate? When you are going to do a local examination, in case of transverse vaginal septa, septa is a thick thing, right? So you won't get any bulging hymen there. And when you are going to ask your patient to cough, cough impulse will be absent. Whereas in cases of imperforate hymen, in case of imperforate hymen. Hymen is a thin membrane. So if you ask your patient to cough and you put your finger on the imperforate hymen, you will feel a impulse there, right? So in cases of imperforate hymen, because hymen is a thin membrane, cough impulse is present. So ask your patient to cough. If you can feel the impulse, that means you are dealing with imperforate hymen. If impulse is not present, then that means you are dealing with transverse vaginal septum. But the best way to differentiate between transverse vaginal septum and imperforate hymen is MRI. Right? That's the best way to differentiate between them. Clear? Any confusions here? No? So we have dealt with those cases where we were getting primary amenorrhea with uterus present and secondary sexual characteristics absent. So we did with primary amenorrhea with uterus present and secondary sexual characteristics absent. Then we did primary amenorrhea with uterus present and secondary sexual characteristics present. Now we are going to do primary amenorrhea with uterus absent. So when we were writing the causes, you had written over here, uterus related problems happen in two cases, Mullerian agenesis and androgen insensitivity syndrome. So if your question is saying that there is a patient with primary amenorrhea with uterus absent, then that means you are dealing with either Mullerian agenesis or androgen insensitivity syndrome, right? So my third case is primary amenorrhea with absent uterus, and in both these cases secondary sexual characteristics are present. Right, and this is Mullerian agenesis, one differential diagnosis, complete androgen insensitivity syndrome, second diagnosis, and partial androgen insensitivity syndrome, third differential diagnosis. Right, now when we say secondary sexual characteristics present, please remember in Mullerian agenesis, breast is also present and fully developed, and pubic hair and axillary hair are also fully developed. Whereas in both complete and partial androgen insensitivity syndrome, breast is fully developed, but pubic hair and axillary hair are not developed. Right, and क्योंकि most important secondary sexual characteristic is breast, तो generally हम ये कहते हैं कि in both these cases secondary sexual characteristics are present, but there is a difference. Mullerian agenesis में pubic hair and axillary hair भी properly present होगा, but in complete and partial androgen insensitivity syndrome, only breast will be properly developed, pubic hair and axillary hair will not be properly developed. But then this is not the most important way of differentiating between them. The most important or the best way of differentiating between them is karyotyping. Right? So best method to differentiate between Mullerian agenesis and androgen insensitivity syndrome is karyotyping. Best method is karyotyping. Right? Now let's go into the details of both these conditions. Mullerian agenesis. Now in Mullerian agenesis, what is the genotype? 46XX, just now I told you. Now if genotype is 46XX, gonads will be ovaries. These ovaries will be normal. And if these ovaries are normal, ovulation will be normal and estrogen will be normal. Right? Now, if estrogen is normal, secondary sexual characteristics will be normal. And because ovulation is normal, so progesterone is normal. So LH and FSH both are normal. Right? So abhi tak I have told you nothing special. I have just told you in Mullerian agenesis everything is normal. Genotype is 46XX, gonads are ovaries which are normal, ovulation is normal. राइट ओव्यूलेशन नॉर्मल है तो प्रोजेस्ट्रॉन नॉर्मल है ईस्ट्रोजन भी नॉर्मल है एंड बिकॉज ईस्ट्रोजन इज नॉर्मल सेकेंडरी सेक्सुअल कैरेक्टरिस्टिक्स आर नॉर्मल एंड बिकॉज प्रोजेस्ट्रॉन एंड ईस्ट्रोजन बोथ आर नॉर्मल सो LH एंड FSH इज नॉर्मल. तो प्रॉब्लम कहाँ है? प्रॉब्लम इज दैट बोथ मुलेरियन डक्ट्स आर एब्सेंट. Both Mullerian ducts are absent. Mullerian agenesis. Now, because both Mullerian ducts are absent, so obviously internal genital organ of females will not develop. So, fallopian tube will be absent, uterus will be absent, cervix will be absent, and upper vagina will be absent. And obviously, अगर किसी female के uterus ही नहीं है, she is going to come to me with complaint of primary amenorrhea. And because her upper vagina is absent, so the length, lower vagina will be present. So in these females, lower vagina which is formed from urogenital sinus, it will be present and ovaries will be present. Just now I told you ovaries are present and they are normal. Absent hota hai all the structures which are formed by the Mullerian duct, that is fallopian tube, uterus, cervix and upper vagina. Right? Now, but upper vagina absent hai, lower vagina present hai, so obviously the length of vagina decreases and these females can also complain of coital difficulties. So they will have primary amenorrhea and once they get married, they will have coital difficulties because their vagina is small in size. Upper vagina is absent. Now in these females, they may have renal anomalies. Right? Most common renal anomaly which you see is renal agenesis because Mullerian duct also plays role in forming the renal system. So the most these patients may be associated with renal anomalies and the most common renal anomaly which you get is renal agenesis or horseshoe-shaped kidney. That is why in all patients of Mullerian agenesis, you should always do IVP. IVP is intravenous pyelography. Right? क्योंकि Mullerian duct not only forms internal genital organs, Mullerian duct also plays a role in forming the parts of urinary tract, in forming parts of renal system. So in these females, you may have renal anomalies and that is why in Mullerian agenesis patient or in Mullerian malformation patients, you should always get an IVP done. Not only this, they may be associated with skeletal anomalies like hemivertebra. Now, if you are getting Mullerian agenesis along with renal anomalies and along with skeletal anomalies, it is called as Mayer-Rokitansky-Kuster-Hauser syndrome. So, Mullerian agenesis along with renal anomalies and skeletal anomalies is called as MRKH syndrome, Mayer-Rokitansky-Kuster-Hauser syndrome, or it is also called as Merck's syndrome, MURCS, where M stands for Mullerian anomalies, MU stands for Mullerian anomalies, R stands for renal anomalies, and CS stands for cervical somite, that is skeletal anomalies. So, केवल इतना याद रख लो MRKH syndrome or Merck's syndrome. So, if you are getting Mullerian agenesis with renal anomalies and skeletal anomalies, that's MRKH or Merck's syndrome. Now, differential diagnosis of Mullerian agenesis is androgen insensitivity syndrome, in which chromosome number is 46XY. And just now I told you that the best way of differentiating between Mullerian agenesis and androgen insensitivity syndrome is karyotyping. So whenever I get a patient of Mullerian agenesis, I should always do karyotyping to rule out. Why am I doing karyotyping? To rule out androgen insensitivity syndrome. I should do IVP to check for renal anomalies. And I should do a skeletal X-ray to check for skeletal anomalies. So these are the investigations which you have to do whenever you get a patient of Mullerian agenesis. Clear to all of you? Yes. Kazi, I think I will be doing that. Just I need some time because I'm very busy these days. So if I get time, I'm planning to upload a revision video for all the NEET PG aspirants for obs and gynae. I'm just trying that, right? Now, coming to management of these patients. In management of these patients, because uterus is absent, can you make these females menstruate? Can these females menstruate? Or can you help them in getting menstruation? No. I cannot make them menstruate because uterus is absent. So I cannot make these females menstruate. But their second problem was that if they get married, they will have coital problems. This is a problem which can be treated. Right? So because their upper vagina is absent, they will have coital difficulties. So in order to treat this problem, I'm going to do vaginoplasty. Now the two questions which they ask you on vaginoplasty is, what is the time at which are you going to do vaginoplasty? Best time to do vaginoplasty is just before or just after marriage. And the technique for doing vaginoplasty is laparoscopic vaginoplasty, which is the Wichet's technique. Or you can go for McIndoe vaginoplasty. Just the names are important. Laparoscopy Wichet technique or McIndoe vaginoplasty. That was done earlier. These days we prefer laparoscopic, that is Wichet technique. Right? Time for doing vaginoplasty is just before or just after marriage. Have you understood Mullerian agenesis? Yes. So the last condition which you have to understand now is androgen insensitivity syndrome or testicular feminizing syndrome. Now in androgen insensitivity syndrome or testicular feminizing syndrome, genotype is 46XY. So all of you know, jab Y chromosome is present, I have just now taught you the gonads will be testes. Now the problem is with these gonads, three problems. These testes are intra-abdominal. These testes are intra-abdominal and so they have increased chances of malignancy. Intra-abdominal testes, they present as inguinal hernia. So intra-abdominal testes patient is going to present to you with inguinal hernias. And the third and major problem which is there in these patients is all these males are completely resistant to testosterone. So first I am telling you complete androgen insensitivity syndrome. And in complete androgen insensitivity syndrome, all these males are completely resistant to testosterone. Right? Now, because they are completely resistant to testosterone, so in intrauterine life, what is going to happen? In intrauterine life, their Sertoli cells are going to produce Mullerian inhibiting factor. Right? They have testes. So testes with Sertoli cells, they are going to produce Mullerian inhibiting factor. Because Sertoli cells will produce Mullerian inhibiting factor, so Mullerian duct will regress. And because Mullerian duct will regress, there is no uterus. Obviously, there shouldn't be any uterus. They are 46XY. right? So 46XY में I don't expect a uterus also. So that is normal over here. They don't have a uterus, right? But now let's see what happens to Leydig cells. Leydig cells भी normally function कर रहे हैं. Leydig cells are functioning normally. They are releasing testosterone normally. But these males are insensitive to testosterone. Now, because they are insensitive to testosterone, they are completely insensitive to testosterone. And because they are completely insensitive to testosterone, so for growth of Wolffian duct, what was needed? For growth of Wolffian duct, testosterone was needed. These males are completely insensitive to testosterone. So now Wolffian duct will regress. And if Wolffian duct will regress, all the organs which are formed by Wolffian duct will not be formed. And all the organs formed by Wolffian duct were SEED, seminal vesicles, epididymis, ejaculatory duct and vas deferens. In other words, male internal genital organs will be absent. इसका मतलब we have a male in whom there are no internal genital organs, right? Neither male internal genital organs nor female internal genital organs, right? Now, in these cases, because they are completely insensitive to testosterone, so testosterone will not be converted into dihydrotestosterone. So they have absent testosterone, practically speaking absent testosterone because they are completely insensitive to testosterone, and absent dihydrotestosterone. And I told you that the natural tendency of the external genitalia is to look like female in absence of any hormonal stimulation. So यहाँ पे there is no hormonal stimulation. So in these males, external genitalia will look exactly like females. And because external genitalia will look exactly like female, at birth, they will be taken as a female child. Because at the time of birth, we look at the external genitalia to decide the sex of the baby, right? So at birth, these children will be taken as female child. Now see what is going to happen at puberty. At puberty, still they are resistant to testosterone. And if they are resistant to testosterone, I told you male secondary sexual organs are formed due to androgens, under the influence of androgens or testosterone. So if there is a male in whom they are completely insensitive to androgen, this means male secondary sexual characteristics will not develop. So they will not have any male secondary sexual characteristic, right? So secondary sexual characteristic of males will not develop. Now comes a very important thing. Now what happens that the testes are secreting testosterone normally. And these testosterone will be increased in these patients because they are not getting converted into dihydrotestosterone. Now this increased testosterone will go in adipose tissue, and with the help of enzyme aromatase, the entire testosterone gets converted into estrogen. So in these males where they at puberty, when they have excessive testosterone and that testosterone is not getting used up, it is not getting converted into dihydrotestosterone also. So this entire testosterone in adipose tissue, it gets converted into estrogen, right? Now these patients are resistant to testosterone. They are not resistant to estrogen. And estrogen क्या कराता है at the time of puberty? Estrogen leads to breast development. So these males will have proper breast development corresponding to Tanner stage 4 or 5. Clear to all of you till here? Now, I told you in females, breast development is a characteristic which is dependent on estrogen. But in females also, for development of axillary hair and pubic hair, which hormone is needed? Androgens. In patients में they are resistant to androgens. So although they will have proper breast development, they will have less pubic hair and less axillary hair corresponding to Tanner stage 1 or 2. So androgen insensitivity syndrome में you get typical question. Question is going to say that patient is coming to you with normal secondary sexual characteristics. She has inguinal hernia. There is complaint of primary amenorrhea. Breast development corresponds to Tanner stage 4 or 5. Pubic hair corresponds to Tanner stage 1 or 2. And uterus is absent. जहां पे हम देखें uterus is absent and breast development is 4-5, pubic hair is 1 and 2. That means they are talking about androgen insensitivity syndrome. Same thing goes for androgen insensitivity syndrome, that their differential diagnosis is Mullerian agenesis, and the best way of differentiating between Mullerian agenesis and androgen insensitivity syndrome is karyotyping. Have you understood androgen insensitivity syndrome? Complete androgen insensitivity? Now tell me, see, ये जो patient है primary amenorrhea के साथ क्यों आ रही है? Patient is coming to you with primary amenorrhea because at the time of birth she was taken as a female child, right? Now when she grew up, when this child grew up and reached puberty, this child had proper breast development. So parents को कोई doubt ही नहीं है कि this child is 46XY and not 46XX. And when they don't have any doubt, they know that they are rearing a female child, they expect the female child to menstruate. And when the child doesn't menstruate, they come to you with complaint of primary amenorrhea. Right? So in this case, you know now what you are going to do. Because you did karyotyping, you came to know whether you are dealing with Mullerian agenesis or whether you are dealing with androgen insensitivity syndrome. Mullerian agenesis is 46XX. Androgen insensitivity syndrome is 46XY. अब जैसे ही हमें पता लगेगा कि I am dealing with 46XY, the first principle in treatment is I am going to let them be females. That is the first treatment. First principle of treatment. This child is going to come to you around 15-16 years जब periods नहीं आएंगे. अब around 15-16 years पे, if you tell a child that you are not a female, you are a male, it will have a lot of psychological trauma on the female and parents. So we have to let them be females. Number one. Number two. In these children, as I told you, they have testes, and these testes in our intra-abdominal and intra-abdominal testes have increased chances of malignancy. So what I have to do is, I have to do a gonadectomy. I have to do a gonadectomy in them. I have to remove their gonads. But then, understand, although the testes has increased chances of malignancy, but the testes are producing testosterone, and it is this testosterone which is leading to breast development. And because I am going to let these females be, these children be females, so I want proper breast development. So although I have to do gonadectomy, I am not going to do gonadectomy immediately at the time of diagnosis. I am going to do gonadectomy after their breast development is complete, which is around 16 to 18 years of age. Right? Are you understanding? Gonadectomy karni hai because there are increased chances of malignancy. But यही gonads बना रहे हैं testosterone, which is getting converted into estrogen, which is leading to breast development. And because I am letting them be females, I want proper breast development. So I am going to do gonadectomy after their breast development is complete, which is around 16 to 18 years. Right? अब एक बार मैंने उनका breast development, एक बार उनकी gonadectomy कर दी. Now they don't have any sex hormone in them, right? And because I am letting them be females, so I will have to give them estrogen replacement therapy. अब बताओ, common sense से बताओ, are you going to give estrogen plus progesterone or only estrogen? These children don't have uterus, so there is no risk of endometrial cancer. So I am going to give them estrogen replacement therapy from 16 to 18 years of age for lifetime. For entire lifetime, I am going to give them estrogen replacement therapy. Right? Then, can I make them menstruate? No, I cannot make them menstruate. But yes, I can make them capable of getting married by doing a vaginoplasty. So in patients of Mullerian agenesis, or like in patients of androgen insensitivity syndrome also, you have to do vaginoplasty. Time and technique is same like Mullerian agenesis. Tell me, can they have their own child, own biological child? No. We have removed their gonads, right? And they don't have ovaries. So they can have child only by adoption, right? Whereas Mullerian agenesis के patients में, can they have their own child? Can they have their own biological child? Yes. How? Because their ovulation is normal, right? So I am going to do IVF followed by surrogacy. IVF followed by surrogacy. So Mullerian agenesis के patient can have their own biological child by IVF followed by surrogacy. And androgen insensitivity में they cannot have their biological child. They have to go only for adoption. Yes, Rahul. In terms of infertility, yes, they have the worst prognosis. Now coming to partial androgen insensitivity syndrome. Partial androgen insensitivity syndrome, as the name suggests, males are partially resistant to testosterone. So in partial androgen insensitivity syndrome, everything is same like androgen insensitivity, but there are only two differences. So everything is same like complete androgen insensitivity syndrome. There are only two differences, and both these differences are happening because they are partially resistant to testosterone. Now, because these males are partially resistant to testosterone, so Wolffian duct will grow and it will partially grow. So, in them, SEED will be present, but they will not be proper. But not proper. Right? Because they are partially resistant to testosterone, so Wolffian duct will be present, but it will partially grow. So SEED will be present, but that will not be proper. And because they are partially resistant to testosterone, so their external genitalia will not look exactly like female genitalia. Their external genitalia does not look exactly like female genitalia, but their external genitalia resembles female genitalia, right? So it's not exactly like female genitalia. External genitalia will have resemblance to female genitalia, and that is what is called as ambiguous genitalia. Ambiguous genitalia, right? So suppose an ambiguous genitalia में कोई भी term use कर सकते हैं. They can say there is clitoromegaly because we are going to take them as females and हमें उनका clitoris बड़ा लगेगा in comparison to a female. We are going to use the term clitoromegaly. Labioscrotal fusion. Right? So if you are getting a question where question में सब कुछ लग रहा है like complete androgen insensitivity syndrome, but एक line दी है कि there is clitoromegaly or labioscrotal fusion. The moment you see that this word, these terminologies are given, it means that there is ambiguous genitalia, and ambiguous genitalia is seen in partial androgen insensitivity syndrome. हाँ, they can be hypospadias, कुछ भी दे सकते हैं term. They can use the term hypospadias, they can use the term micropenis, any term. I have told you all the terminologies related to ambiguous genitalia. Right? So anything can be given. They can give you clitoromegaly hai, labioscrotal fusion hai, hypospadias or micropenis, anything. So if the terminology is related to ambiguous genitalia, right, then I am going to say that I am dealing with partial androgen insensitivity syndrome. Clear to all of you? Yes? So look at this question and then we are going to end the class. A young female presented to you with primary amenorrhea. On examination, there is normal breast development and absent axillary hair. So I told you, जब भी normal breast development हो and absent axillary hair हो, you always have to think about androgen insensitivity syndrome. Pelvic examination revealed clitoromegaly. On ultrasound, gonads are visible in inguinal area. So I know I am dealing with androgen insensitivity syndrome, and because they have used the term clitoromegaly, what will your answer be? So I'm just waiting for your answers and then we'll end this session. I have started getting answers. Excellent. That means all of you have understood. So the answer is partial androgen insensitivity syndrome. Right? So that completes today's session. This is a very, very important session. All of you should revise this properly, and all the FMG students who are watching this session and they have to give their FMG exam in June 2022, we have an epic crossover session by Dr. Rohan, Dr. Ranjan and myself on Marrow's YouTube channel on 12th of April at 7 p.m. where we are going to discuss in detail with you how to prepare for your upcoming FMG exams in the last 60 days. What are the things which you have to keep in mind in last 60 days when you are preparing for your FMG June 2022 exam. So if you have any queries which you want us to answer, please write to any one of us on our Instagram handle or send in a message on mail. And don't forget to watch that session. That will be really helpful for all of you. Take care. Bye. Keep studying.